Cardiac tamponade. It's a condition that may sound unfamiliar, but for aspiring nurses, understanding this life-threatening condition is crucial. Imagine a scenario: you're an ER nurse and a patient arrives complaining of chest pain and shortness of breath. Their blood pressure is dropping. Could this be a heart attack? Possibly. But what if it's something even more insidious, something that requires immediate intervention to prevent a tragic outcome? This is where the knowledge of cardiac tamponade becomes paramount. Cardiac tamponade is a medical emergency where the heart, our very own life force, is squeezed and constricted, struggling to perform its vital duty of pumping blood. This occurs due to a buildup of fluid in the pericardial sac, the protective double-layered membrane that surrounds the heart. This fluid accumulation puts pressure on the heart, restricting its ability to fill with blood and effectively pump it throughout the body. Think of it like at the base. The heart is like a balloon, and the pericardial sac is like a plastic bag surrounding it. Now imagine someone slowly pouring water into the bag. As the water level rises, it starts to compress the balloon, making it harder and harder for it to inflate. This is essentially what happens in cardiac tamponade. The heart, under increasing pressure from the fluid buildup, can't expand properly to receive blood, leading to a cascade of life-threatening consequences. The purpose of this comprehensive guide is to equip future nurses like you with the knowledge and understanding of cardiac tamponade, from its underlying mechanisms to its diagnosis and treatment. We'll delve into the causes, symptoms, and diagnostic tests that help identify this silent threat, empowering you to provide timely and effective care. Remember, in the realm of healthcare, knowledge is power, and understanding cardiac tamponade could mean the difference between life and death for your future patients. To effectively combat cardiac tamponade, we must first understand its insidious nature. This condition arises when excess fluid accumulates within the pericardial space, the normally minuscule gap between the two layers of the pericardium, the sac that envelops the heart. This fluid buildup, known as pericardial effusion, can stem from various causes which we'll explore later. As fluid accumulates, it exerts relentless pressure on the heart, compressing it from all sides. This external pressure hinders the heart's ability to expand fully during diastole, the relaxation phase of the cardiac cycle when the heart chambers fill with blood. Consequently, less blood enters the ventricles, reducing the heart's output, the amount of blood pumped with each beat. The body, in its infinite wisdom, attempts to compensate for this reduced cardiac output. The sympathetic nervous system kicks into gear, increasing heart rate and constricting blood vessels to maintain blood pressure. However, these compensatory mechanisms are often insufficient to overcome the relentless pressure exerted by the pericardial fluid. As pressure mounts, the heart becomes increasingly compromised, leading to a decline in blood flow to vital organs. This can manifest as low blood pressure, a telltale sign of inadequate cardiac output. Moreover, the pressure imbalance within the heart can disrupt the normal electrical activity, potentially leading to life-threatening arrhythmias or irregular heart rhythms. Cardiac tamponade rarely appears out of nowhere. It's often a consequence of other medical conditions or events. Understanding these underlying causes is key to recognizing and managing this condition effectively. One of the most common culprits is pericarditis, inflammation of the pericardium. This inflammation can be triggered by viral or bacterial infections, autoimmune disorders like lupus, or even as a side effect of certain medications. When the pericardium is inflamed, it can produce excess fluid, leading to pericardial effusion and potentially tamponade. Trauma such as a penetrating chest injury or blunt force trauma from a car accident can also cause cardiac tamponade. These injuries can damage the heart or surrounding blood vessels, leading to bleeding into the pericardial sac. The rapid accumulation of blood can quickly escalate into a life-threatening situation. Certain medical procedures, while intended to be beneficial, can sometimes inadvertently lead to cardiac tamponade. For instance, cardiac catheterization, a common procedure used to diagnose and treat heart conditions, carries a small risk of puncturing the heart or a nearby blood vessel, potentially causing bleeding into the pericardial sac. Beyond these direct causes, certain risk factors can increase an individual's susceptibility to developing cardiac tamponade. Patients with pre-existing conditions like cancer, particularly lung cancer or breast cancer that has spread to the chest area, are at a higher risk. This is because cancerous cells can irritate the pericardium, leading to fluid accumulation. Section 4. Recognizing the warning signs. Symptoms of cardiac tamponade. Recognizing the subtle and often non-specific symptoms of cardiac tamponade is crucial for early diagnosis and intervention. These symptoms can vary depending on the rate and volume of fluid accumulation, making keen observation and a high index of suspicion essential. One classic but not always present triad of symptoms known as Beck's triad can raise red flags for cardiac tamponade. This triad includes hypotension, low blood pressure due to reduced cardiac output, muffled heart sounds. As fluid accumulates in the pericardial sac, it acts as a sound barrier, making it difficult to hear the heart sounds through a stethoscope. Jugular venous distension, or JVD. The veins in the neck become visibly engorged as blood backs up due to the heart's impaired ability to pump efficiently. Another characteristic sign is pulsus paradoxus, an exaggerated drop in systolic blood pressure during inspiration, the act of breathing in. Normally this drop is minimal, but in cardiac tamponade it becomes more pronounced, often exceeding 10 millimeters of mercury. Patients with cardiac tamponade often experience dyspnea or shortness of breath as the heart struggles to pump enough oxygenated blood to meet the body's demands. Chest pain, while not as prominent as in a heart attack, can also occur and is typically described as a feeling of pressure or tightness in the chest. Section 5. Detecting the silent killer. Diagnostic tests. Diagnosing cardiac tamponade requires a multifaceted approach, combining clinical findings with confirmatory diagnostic tests. One of the most valuable tools in our arsenal is the echocardiogram, a non-invasive imaging test that uses sound waves to create real-time pictures of the heart's structure and function. An echocardiogram can reveal the presence of pericardial effusion, showing the fluid surrounding the heart. Moreover, it can assess the severity of the tamponade by visualizing the heart's chambers and their movement. In tamponade, the heart chambers, particularly the right atrium and ventricle, appear compressed and may even collapse during diastole due to the external pressure. While the echocardiogram reigns supreme in diagnosing cardiac tamponade, other tests provide valuable clues. An electrocardiogram or ECG, which records the heart's electrical activity, may show non-specific changes such as low voltage QRS complexes or electrical alternates. An alternating pattern of QRS complex amplitude suggesting the heart is being squeezed. A chest X-ray, while less sensitive than echocardiography, can sometimes reveal an enlarged cardiac silhouette, suggesting fluid accumulation in the pericardial sac. However, it's crucial to remember that a normal chest X-ray does not rule out cardiac tamponade, as the amount of fluid required to cause significant symptoms may not always be visible on X-ray. Section 6. Winning the battle. Treatment options. Treating cardiac tamponade is a race against time, demanding prompt and decisive action to relieve the pressure on the heart and restore normal cardiac function. The primary goal is to rapidly remove the pericardial fluid, allowing the heart to expand and pump effectively once more. Pericardiocentesis, a potentially life-saving procedure, involves inserting a needle through the chest wall into the pericardial sac to drain the accumulated fluid. This procedure is often performed under echocardiographic guidance to ensure accurate needle placement and minimize the risk of complications. The drained fluid can then be sent for laboratory analysis to determine the underlying cause of the effusion. In cases of recurrent cardiac tamponade, or when the fluid is loculated, meaning it's trapped in pockets within the pericardial sac, a surgical approach known as pericardiotomy may be necessary. This involves creating a window in the pericardium, allowing for more extensive drainage and preventing fluid from reaccumulating. While these procedures address the root cause of cardiac tamponade by removing the pericardial fluid, supportive measures are equally crucial. Intravenous fluids or IV fluids are administered to increase blood volume and support blood pressure. In severe cases, medications called inotropes may be given to enhance the heart's pumping ability.